Welcome everybody to the December meeting of the Fort Worth Surgical Society. I want to thank first of all everybody in our remote sites for joining us tonight. This is, if you haven't been downtown, we have one of the best Christmas trees our city has ever had. This is a Saturday night picture. My grandkids are somewhere in this crowd. We were downtown looking at the downtown Fort Worth Christmas trees. So this is our December meeting. I want to welcome everybody here tonight. We don't have any medical students with us, but Aaron Eves is with us. Aaron has joined us all season. He got all A's in his first semester of college at Hill College. He is hopefully on the way to medical school. And so we welcome everybody with us tonight, especially our remote sites. I want to thank, as always, our Moncrief partners, Dr. Argenbright and his crew, and thank Don Hauser and Melanie, everybody for being so kind to us. This has been a great relationship. There they are. And we hope Jonathan gets back to work very, very soon. This is your executive committee. Every month I have to keep working on the JPS folks to get over here, but as always, if you have any ideas, 24/7, of a new RJ White speaker, a speaker during the year, please let me know, or questions about any issues. This is our schedule going forward. 2017, we're full. We're also booking talks into 2017-2018 year. The March 14th speaker, this is a drug company that called me up, wanted to put a speaker in. We have an alternate, the speaker that Lee Blumendahl had over at the Texas Surgical in Dallas for the ethics lecture. Anne Marie Warren and I have been emailing back and forth. I missed that lecture on surgical burnout, or surgeons burning out, and so we may have that as our speaker in March.
John, what's the chief resident from Peter Smith going to talk about?
He also has been emailing with me, and he thinks it's going to be an endocrine surgery talk. So he has put some things together. I will have that. I'll send an email to everybody about that. Dr. Dykshaw is going to talk about complications of bariatric surgery, kind of where we are in 2017. And I'm excited about our RJ White speaker, Dr. Joseph Mill. That should be M-I-L-L-S. He's chairman of the department at Baylor College of Medicine in Houston. He's going to give us a vascular surgery update. We have not had a vascular surgery RJ White talk since 1987. Lots changed, lots of endovascular stuff. A lot of people feel that pendulum has swung too far over to endovascular, and the expenses, the bills that are being submitted for all this endovascular work is not going to be sustainable. So that's going to be a very, very interesting, controversial lecture in May of 2017. We also have an RJ White speaker for 2018 who's going to be an anesthesiologist. He's going to talk to us about the ERAS protocols. He is the country's expert, and I think this ERAS that we heard about 2 lectures ago from Dr. Vasquez is going to be the hot thing coming up and be forced upon us. So we have an interesting lecture from Duke in 2018. So a good schedule. A few CME things that are coming up. If you haven't seen these, there is a great course up at Harvard in Boston if you like the snow and cold weather, and it's horrible up there in January, but good seafood. And of course, for general internal medicine for specialists, if you've got a board exam coming up, that can be helpful. Dr. Steve Brotherton, who's with us tonight, informed me of this interesting looking seminar coming up. It's Saturday, February 11th, with some handouts out there for everybody. It's called Healthcare in a Civil Society, Improving the Health of Populations, along with Dr. Brotherton, who's in the panel, Stuart Pickell, Mayor Betsy Price, Pete Guerin, and the folks from the new TCU Medical School. This should be very interesting, and I'm going to this one. This spring, the North Texas and South Texas chapters of the American College of Surgeons are going to be meeting together in Austin. Watch for, I think I just got an email asking for abstracts, so watch for this meeting. It's going to be a good combination of papers, February 23rd through 25th. A hernia society meeting down in Cancun in March if you're tired of the cold weather. Colorectal meeting in Seattle in June. So as I mentioned last meeting, we have a new relationship with the Fort Worth Dental Society. They're very anxious to have 2 social events with us during the year. We had a great time down at the Beaumont Ranch in Grandview shooting with in a sporting clay shoot with the Fort Worth Dental Society, and so they would want to cook up with us, and so this is cooking. We had a lot of fun and we enjoyed them. Anyway, tonight, our without further ado, our speaker, and I want to thank Noel for offering to come and speak to us tonight. Noelle is going to talk to us about the morcellation controversy. And I think this is really interesting. I'm looking forward to what she has to say a lot. I've never, not doing a lot of surgical oncology, I was never involved with this, but I do remember it was such a big issue with our general oncologist at the time. Noelle got her undergraduate degree in biology at the University of Texas at Austin, medical school at Baylor College of Medicine in Houston. You may have met my dad down there because he was a professor of surgery. She did her residency in OB-GYN at the University of California in Irvine and Orange, California, and 4 years of a Gen Oncology Fellowship, again out in Irvine. Noelle's a very busy Gen Oncologist. She's a great speaker. And I do want to note, looking through her CV, that her first peer-reviewed article that she published was in 1993 in the journal Circulation, and she was a co-author with Dr. Denton A. Cooley on an article entitled Aortic Valve Replacement in the Elderly. So that's kind of interesting. But anyway, Noelle's going to talk to us about the morcellation controversy. Is there still a role for morcellation? And if you don't know what morcellation is, you're going to learn about it. So Dr. Noelle Cloven. Noelle, thank you.
Okay, well, hi everybody. My name is Noelle Cloven, and I'm a local gynecologic oncologist with Texas Oncology here in Fort Worth. And I want to thank everybody for coming today. I know it's close to Christmas, and most people are at Christmas parties, or they're out to dinner somewhere, or they're with their families, or Christmas shopping. So thanks everybody. My talk is a talk that really has been, just for the past couple of years, has been kind of an important topic for everybody. I do want to, I have nothing to disclose except for two things. One is that I'm a gynecologic oncologist, and so that's going to bias my opinion of this topic in some way. And the other is that I personally don't use a morcellator. So as you can see from this graph, if you look at hysterectomies over the years, and this dates back to 1990, the red line represents abdominal hysterectomies, and that was how the majority of hysterectomies have always been done. The pink line represents minimally invasive surgery, and that includes laparoscopic assisted and robotic hysterectomies. And I just think it's interesting to look at the trend over the years, particularly after 2007, there's a big jump in both laparoscopic and robotic hysterectomies. And that's what's really led to the push for morcellation. It's pretty obvious why people would want to have minimally invasive surgery. You have a quicker recovery time, the hospital stay is less, the incisions are smaller, and we really, we've tried to see how we could apply this type of surgery to all of our patients. Not just patients that are either thin or have, maybe small uteruses, or who don't have cancer. And so that's been something that's really changed a lot since I've been doing surgery. This just shows an example. The midline, where I trained in California, we didn't do a lot of laparoscopic cancer surgery. People were doing it, but really the only thing I did laparoscopically during my fellowship was to take out ovaries that were normal for prevention of breast cancer or ovarian cancer. I didn't have a lot of experience with laparoscopy. When a woman was diagnosed with endometrial cancer, ovarian cancer, you did a midline surgical incision, and you can see, this was the results. I mean, it's not the best cosmetic result. A patient that has minimally invasive surgery, sometimes you can't even see the scars. You go into the belly button, the scars are small. So you can see why this is something that's very desirable from a patient standpoint. I just thought this was just kind of funny. I don't know. They look kind of like they're doing the thing with the Titanic, but things have definitely changed a lot since your mother had a hysterectomy. So minimally invasive surgery benefits a lot of women, and the morcellator, like I said, well, I personally don't use it. I've only seen it used, is a way to convert what would have been an open surgery through a midline incision. For example, a woman who has an enlarged uterus with what are presumed to be uterine fibroids, and you can't remove that through a tiny hole that's about 1 centimeter in size. So you have to find some way to get that out, and it can't come out vaginally either if they're really enlarged. So what the morcellator does is it divides the uterus or the fibroid or whatever you're removing into smaller pieces to facilitate its removal. okay? And so the benefit is that it could potentially allow more women to undergo minimally invasive surgery and prevent the bigger, you know, cosmetically less acceptable incision, the longer hospital stay, you know, possibly more blood loss, more hernias, all the things that you get with the bigger incisions. Morcellators, I mean, this is something that's really been going on for a while. I mean, you can see that, you know, people started using them about 10 years ago, but 2009 was when it really took off, and 2012 was kind of the pinnacle of when, when about 15% of surgeries were, you know, for fibroids were using a morcellator. So as with any instrument, there's risk, and you know, some of the risks are pretty obvious, like vascular and bowel injuries. I mean, that's true of any surgery that you're doing in the abdomen. But one thing that I think a lot of people didn't think about is that you can get dissemination of benign tumors. A person that has benign fibroids, those can, as the tissue is morcellated, can be disseminated throughout the abdominal cavity. It can happen with endometriosis. You know, everybody's heard of port site metastases, or I'm sure a lot of people who are general surgeons have taken care of patients that had endometriosis of their abdominal wall. But then probably the biggest risk to this procedure is the dissemination of cancer. So this kind of all came to attention back at the end of 2013, and this is just kind of a little timeline just so I can kind of go over the history of this with you guys. The Wall Street Journal called attention to a case, and it was a patient that had minimally invasive surgery for what were thought to be benign uterine fibroids, and a power morcellator was used to remove the fibroid tumors. And later, when the final pathology report came out, it turned out that the patient had a high-grade leiomyosarcoma. Then, several months later, the New York Times did a follow-up article with this increased media attention. A couple months after that, the FDA got involved and put out a statement that quoted a 1 in 350 risk of a high-grade sarcoma in patients who are thought to have fibroids. And that led to many institutions banning the use of morcellators. And this had a big impact, I mean, not really on my practice as an oncologist, but you know, a lot of OBGYNs were using this morcellator routinely to do, you know, their surgeries. And so if it's banned from an institution, you know, you have surgery scheduled, you have to reconsent the patients. Then Ethicon recalled their device, and then the FDA issued a black box warning, which is, you know, the strongest warning, which indicates a significant danger to patients. And so all this happened back in 2014, and I guess probably what made it even worse is this patient happened to be the wife of an anesthesiologist in New York, and it really just kind of unleashed, you know, just a whole, you know, media-driven, you know, you can't use these morcellators, they're, you know, and they were really, I mean, in my opinion, they were blaming something on a device, which is really something that is, you know, a physician and the patient is more responsible for the surgery. So take it for what you will. So here's the questions that came out of that. First of all, I think a lot of us were a little bit surprised to hear the incidence of sarcomas as being 1 out of 350 surgeries. That seemed a little bit high compared to, you know, what we're used to quoting patients. You know, of course, you know, again, my bias as a GYN oncologist, I do see a lot of sarcomas, but these are rare tumors. And I see patients that had a hysterectomy and then were found out later to have sarcomas. So to me, it seems like something that happens all the time, but in reality, it's not very common. Another question is, well, how can you diagnose somebody with a sarcoma preoperatively? Finally, well, what happened? I mean, if you morcellate a sarcoma, you know, do these tumors have a bad prognosis anyway? Does it really affect the prognosis of these patients if it's morcellated? Or is the outcome going to be the same no matter what? And then you really have to think, if we're not going to be doing minimally invasive surgery due to a fear of disseminating a rare tumor, what's the potential increased risk to the patients as far as when you do an abdominal hysterectomy, there is more morbidity, there's more time off work, potentially more mortality. So increasing the numbers of abdominal hysterectomies related to this is kind of the counter position. So one thing that we looked at was preoperatively, you know, how are we going to try to figure out which patients can have minimally invasive surgery and who can't? So a lot of people thought maybe an MRI would be a good idea, and that way you could tell if it was a fibroid or a sarcoma. That turned out not to really be true. If you look in a textbook, they say that the way that you diagnose a sarcoma of the uterus is any rapidly growing fibroid. It turns out that's not really true. Endometrial biopsies in the office aren't very good at detecting sarcomas because they're more in the muscle of the uterus, so you can't really get to them with a biopsy or DNC. One strategy is to exclude high-risk patients. Other people felt that you just had to improve or enhance the surgical consent. Some hospitals that I worked at, they had a separate consent. You had the surgical consent, and then if you used the morcellate, you had a special consent for that. And some people even went so far as to consider if a patient was going to have surgery with a morcellator, that a peer review of that case prior to scheduling it by a panel at the hospital would be necessary. So looking at who's at increased risk of cancer, I mean, it's really pretty obvious. I mean, the people that you would think would have a higher risk of cancer, anyone who's postmenopausal. As with any cancer, age is probably one of the biggest risk factors. You can see, in the graph on the one side that, people under 40, it's pretty rare, but as you get, older than, closer to 60, then the risk really increases. Anyone who's used tamoxifen, pelvic radiation, and of course family history, people who have Lynch syndrome, a lot of first-degree relatives that have endometrial or colon cancer, those patients are going to be at increased risk of having cancer found at the time of the hysterectomy. This really is just a couple of studies that I'm not going to really get into that talk about how you really can't diagnose these any sort of sarcoma preoperatively. So this I do want to spend a little bit of time on. This was a study that was published in 2014. It's not a very big study, but you're not going to find big studies because sarcomas are rare, so there's no big studies of sarcomas. But this was a retrospective study over a pretty long time period, over 5 years. They had 58 patients with sarcomas, where 39 of them had an abdominal hysterectomy where the uterus was removed intact, and 19 had minimally invasive surgery with morcellation. And what they found in this study was that there was a statistically significant increased risk of intraperitoneal recurrence and decreased survival in patients that had morcellation. And they found that the risk of recurrence was up to 3 times compared to patients that had an abdominal hysterectomy. And this is just the same thing in a graph form. You can just see the recurrence-free interval for an abdominal hysterectomy was 25 months, and the recurrence-free survival in patients that had morcellation was 10 months, so less than half. So back to, well, what happens if you have a leiomyosarcoma and it's not morcellated? This is another retrospective study, again, over a long time period of 20 years, where they had 100 patients with early stage leiomyosarcomas. And these, no one really knows what's best to do with an early stage leiomyosarcoma. We're just kind of all over the place. We know there's a high risk of recurrence. Most of the time we don't recommend radiation. Chemotherapy's never really been proven to help anything, but sometimes you do anyway because there's such a high risk of recurrence. But in this study, you can see it was kind of a third were observed, a third had radiation, and a third had chemotherapy. But even with that, there was a 70% recurrence rate. So these are a non-morcellated patients. So this is kind of a aggressive disease no matter how you look at it. In this particular retrospective paper, there was an association of increased survival with chemotherapy. So this was another thing I thought was kind of interesting. This was published in the American Journal of OBGYN, and this was one of those decision tree analysis studies. So it's not, really something that would happen, but it's kind of one of those what if, 100,000 women had hysterectomies study, but you kind of follow it down. And, the bottom line is they said that if you did abdominal hysterectomies, and not many people die from a hysterectomy, but I guess more people do die from an abdominal hysterectomy than from a robotic or a laparoscopic hysterectomy. And the laparoscopic group also had significant decrease in postoperative morbidity, such as transfusions and blood clots and infections and hernias. So that's just kind of looking at, well, if we didn't ever do another morcellated case and we did all of these patients abdominally, there's also some sequelae from that also. This is another study that was published about a year ago in Michigan, and they found that there was everybody's real big on hospital readmissions now, and you're all kind of looking at, people are looking at that a lot. And they said if you did abdominal hysterectomies, you're going to have 25% more hospital readmissions and more major complications. So this is a statement that the AAGL made to the FDA back in 2014, and they basically said, if the FDA is going to take away the morcelator, you're going to have 17 more women dying per year from a hysterectomy. Their recommendation was to improve and not abandon the power morcelator, and that it should be made as an available option in low-risk women who have informed consent. So my opinion on it, as biased as I am, I don't like it, I don't do it, but I agree that I don't think it should be abandoned. I think that there is a role for morcellation. I think that people need to be informed of what the risks are, and I think that a woman who's having a hysterectomy or a person that's having any other type of surgery where there's a potential risk of cancer needs to be informed and talk to their physician and make a decision as far as what type of surgery is right for them. There's no data on this, but I thought about this, and for years, when we do hysterectomies or for cancer surgery, we like to do these en bloc resections. So typically, when you're doing a surgery, you like to remove things in one piece. But people, even with vaginal hysterectomies, the big uterus, where I trained, sometimes we, you flip the uterus around, you kind of cut it, kind of core it out to try to remove it through the vagina. What about when you do a myomectomy? There's patients that you just cut the fibroid out and you don't do a hysterectomy. Is that considered morcellation? What if you resect it hysteroscopically? Or, what if you, do a myomectomy to improve exposure at the time of an abdominal hysterectomy? So there's all sorts of things that, that we do that are kind of like morcellating, but we're doing them open. So, I don't really know how that falls into this whole thing. Moving on to intraperitoneal dissemination after morcellation. This is a study that I thought was interesting that I had looked up when I had a similar case. And it was a retrospective study of 1,000 patients that had morcellation. And they found that the rate of leiomyosarcoma was very low. This is more along the lines of what we typically think. It's less than 0.09%. But there was a high rate of dissemination of disease at that time, not all cancer. And if you look at these 1,000 cases of morcellated resections, these were women that all were thought to have leiomyomas or benign fibroids. There were 10 cases that were variants or had atypia. There were 2 cases of actual malignancy, either an endometrial stromal sarcoma or a leiomyosarcoma, and the other 1,078 cases were all fibroids. And if you follow up, one of the patients with fibroids had dissemination of their tumor. None of the patients that had cancer had any documented dissemination, and 4 of the cancer with patients with atypical variants had dissemination. This is just a slide that talks a little bit more about that. Nobody really knows what to do. I get patients referred to me that have had, they've had a laparoscopic assisted hysterectomy, and either a morcellator was used, or it was removed vaginally, or it was removed in pieces, and then when the pathology comes back, it's a sarcoma, and nobody, we don't really know, well, what do you do? Do you then give chemo? Do you do a CT scan? Do you go back and operate and look? And this was an example of 14 cases in this study where they went in and they looked with a laparoscopy after they'd healed from the original surgery, and they found out of the 14 that 9 of them had evidence of peritoneal dissemination at the time of follow-up laparoscopy. This is one of my patients, and this is a woman that had had a myomectomy for a benign fibroid that was morcellated. She, I believe she was in her 40s. She was referred to me with what was thought to be ovarian cancer. She had multiple large intra-abdominal masses. CT scan said cancer. We went in there and I guess, do I have a pointer? But I don't know how many OBGYNs here, but the uterus is on the other side over there, and the uterus was normal. These other things are just all, you can see there's a piece of small intestine. It kind of looks like a kidney, but it's not. There was a omentum that had a very large fibroid on it. And these were all tumors that were just attached to different, okay, cool. So yeah, so here's a big leiomyoma that was on her omentum. Here's your small intestine. This is another huge tumor that was just stuck to her peritoneal cavity, and then here's her uterus. And all of this was benign. I mean, none of this was cancer, but this was just a patient that had had a morcellation for fibroids several years ago and presented with a big belly. So again, many questions remain. What do you do in a patient that's had morcellation? How do you avoid morcellating in known cases? And this brings up kind of the most recent thing in this discussion has been the use of a bag morcellator. And I'm not going to bring any product names into this, but recently the FDA did approve a product for morcellation. This is a picture of it. And you can see the way that it's done is the uterus or the tumor is removed. There is a bag it's almost like an Alexis retractor that you would use at surgery that's placed in through an umbilical port that's several centimeters in size. The abdomen is insufflated into this bag, so you have your pneumoperitoneum inside the bag. And then the mass is somehow, I guess it's placed in it before you re-insufflate, and then it's morcellated in the bag, and then the bag is removed. And like I said, it was recently FDA approved. I haven't seen it. I know there's a lot of interest in it as a way to still do minimal invasive surgery while minimizing risk to patients. Again, I don't know if it's something that I am personally going to use, but I think it's kind of a step in the right direction. I think if it's done right, it makes sense that it could possibly work. So I think I already went over this a little bit. This is just what I do in patients that are referred after they've had a morcellation. I usually start with a CT scan. If, in talking to the patient, we feel like it's best to do a laparoscopy and look in there, or robotic surgery, we do that. I've gone in and found pieces of uterus stuck to the bowel in patients that had endometrial cancer. Usually if I go in laparoscopically and see dissemination, I'll usually go ahead and proceed to a laparotomy just to make sure you can really look around at that point. If you have a high-grade sarcoma and it's been morcellated, I think a lot of people would then recommend chemotherapy just to prevent, if there's any microscopic dissemination. If you have an endometrial stromal sarcoma, which is a more rare and indolent sarcoma, some people are using MEGACE or aromatase inhibitors. So for future considerations, this is the last slide. Just recommendations. Don't perform morcellation in women that, are known to have cancer. I also wouldn't recommend it in a woman that is undergoing a risk-reducing surgery, because in patients that are BRCA positive or have a familial predisposition to cancer, there's a certain percentage of those cases that microscopically they're then found to have cancer, so I wouldn't recommend it in those cases. You want to make sure you've done a good workup, just kind of go back to med school, what we all did, do an exam, you make sure their pap smear is normal, just do the things. If they're bleeding, you probably want to do a biopsy beforehand, any imaging that you think might be helpful, do that. There are alternatives to morcellation. You can still do an abdominal hysterectomy. And what I do, we do endometrial cancer with robotic surgery, I would say is probably the standard of care now. And sometimes people have fibroids, and so we do our whole surgery robotic. We do the hysterectomy. I try to remove it vaginally in one piece. If it doesn't come out, I then do the lymphadenectomy, put those in bags, and at the end of the case, I just do a little mini laparotomy, just, about this big. That's all you need to do, kind of above the pubic bone. It's cosmetic. Reach my hand in there, pull it out. The patients still go home the next day. It doesn't seem to really add anything to their recovery, but then you're not risking, disseminating cancer. Informed consent, obviously, everybody needs to know what the risk and benefits are. you know, if you're considering using a morcelator, you know, most people are pretty educated, and you know, it's something that, you know, you just have to talk through with the patient. I think the bags are a good step. I think that probably before using it, there's going to have to be some training involved as far as how to deploy the bag, you know, how to morcelate in the bag without tearing it. You know, you certainly don't want to do any bowel injuries, so you know, that would be something that for the future. And I think that's all that I have. So thank everybody. I hope that wasn't too gynae-like for those people that are surgeons, and I probably said the word hysterectomy like 100 times, but I mean, that's all I do, so I'm sorry. It's that's all I know how to do. Okay, so question?
Yes, on your slide on measures for pre-op diagnosis, I didn't notice a PET scan on there.
Yeah, so the question is about a PET scan. Should you do a PET scan? It's real difficult to get PET scans approved, honestly. I mean, they're very specific, you know, for what they'll approve it for. And sarcoma isn't one of the diagnoses that you can get it very easily. In fact, I have a peer-to-peer review at 7 o'clock about that. No, tonight. But yeah, you just can't really get them. And it probably would be helpful, you know, but it's hard to get that paid for. The only gynecologic cancer that we can, and we even have sometimes the cervix, but that's the only one that's FDA approved. It's even hard to get for patients with endometrial or ovarian cancer, or documented cancers. It's difficult to get a PET scan. With the mass, it's really iffy if you can get it covered.
Interesting.
By the way, very good talk. I'm probably the farthest from your specialty of anybody in the room, and it was very lucid, and I was able to follow it quite well. I have partial background as well in medical ethics, and part of the conflict that's emerging is going to keep getting worse is the push between individualized versus population medicine. This looks like this could be a barbed wire borderlands. If you're looking at somewhere, there's 17 more deaths from all abdominal hysterectomies every year that can get pushed from federal payers and even private payers. Well, no, we got to go back this direction. Whereas you're trying to make a decision on an individual patient that risk isn't justified. Where's the conversation on that part of this going?
Yeah, I think that really is the conversation about this whole thing. That's the whole point. The question was talking about the whole ethical dilemma, you know, when, you know, now we're getting, you know, as physicians, you know, we feel that it's our duty and our job to talk to patients and explain, you know, what the differential diagnosis is and what their options are for treatment and what the risk of different options, and that's a decision that you make between a patient and their physician. You know, it is getting taken out of our hands. I mean, there's just things that, you know, are kind of beyond our control, and I don't know, you know, there's different societies that stand up and make statements about different things. You know, I think our hands are kind of tied. Like I said, when they took this, you know, when a lot of the hospitals took the morcelator away, I think it had a big impact on a lot of individual patients. And again, I'm not a big fan of the morcelator, but I think that it should be someone's, you know, it's a device, and you know, it should be someone's decision to make with their physician whether or not they're going to have surgery with the morcelator or not. And there are people where, based on their beliefs that, or their lifestyle, or you know, there's a lot of factors that come into play. Maybe they're a caregiver for somebody. I mean, they need to have a minimally invasive surgery, and they're a low risk for cancer, and you've educated them, and you know, maybe that's their choice. But it's go ahead.
I had the impression earlier in your talk that the morcelator was sort of taken off the market. But my question is morcellation being done still today in gynecology, and is morcellation being done in other surgical specialties, in general surgical oncology, for example, in minimally invasive pancreatic and liver surgery and colon cancer? So is morcellation still being done?
It's done. There's certain hospitals that won't allow you to do it, but other hospitals do allow it. And I'm not sure for surgical or colon, or I don't know if that's in.
I thought they did morcellation for spleens and used bags.
Yeah, maybe or kidneys, or yeah.
Huh?
Spleens or kidneys, you'd think would be a good example of when you could do it, but
Right. I
You
think
know.
they, I think they are, yeah.
Yeah.
Noel, I like to talk to, as Steve did, and I really was ready to applaud you when you got to the punchline about the mini Fannin steel incision at the end of the cases. That,
Mini
you know, just doing a small enough one and doing it in a cosmetically acceptable area and so forth to get a relatively large tumor out that you couldn't get out in the scope. My question about that is, do you use a bag when you get to that stage to try to further enhance the
Yes.
cancer's principles?
So the question he was asking, you know, we talked about within a cancer case, do you, when I said that the uterus was too big to remove vaginally when we're doing robotic surgery, and I would just make a mini Fannin steel and then reach in there and get my hand, I do usually use a bag. And the reason for that is while you're removing the lymph nodes or while you're kind of waiting to do that, especially with the large cancer, you know, you've got the cervix up in the abdomen, and you know, there could be cancer cells that are falling out during that time. So I do try to, if I can, put it in a large bag. It can sometimes be kind of awkward though if it's a really big uterus. So, and I haven't had any you know, problems with recurrences in the incision, in a Fannin steel incision or vaginal recurrences.
Thank you.
You're welcome.
Are there any questions out at in Decatur? Tom, anybody out there have a question for Dr. Cloven? Yep, you have a
No
question?
questions. It was a wonderful talk. Thank you.
Oh, good.
Thank you.
If there are other questions, I think we'll adjourn for a few minutes before our business meeting. Thank you everybody for joining us out there. Have a Merry Christmas. Have a Merry Christmas. If you have any thoughts about a next meeting or topics, let us know. The next meeting will be in January. We'll keep you informed. It will be probably an endocrine surgery lecture by the chief resident of JPS. So again, thank you and Merry Christmas.